Welcome to Roadmap to Residency. Today we are tackling thyroid disorders for the United States Medical Licensing Examination Step 2 Clinical Knowledge Exam. This is not your typical lecture. We are focusing on high-yield question stems, test-taking strategies, and the clinical pearls that will help you answer board questions correctly. If you find this helpful, please like, subscribe, and check out our expert tutors and residency advisors at roadmaptoresidency.com. Let us dive in. By the end of this video, you will be able to recognize classic question stems for hypo and hyperthyroidism, apply the thyroid nodule workup algorithm that boards love to test, identify the life-threatening thyroid emergencies, and know the key distinguishing features of thyroid cancers. Remember, we are not teaching basic pathophysiology here. For that, I recommend your first aid for Step 2, your UWorld question bank, and your favorite review resources. What we are doing is showing you how the test writers think. Here is your mental framework for every thyroid question. First, determine if the patient is hyperthyroid or hypothyroid. The buzzwords are your friends here. Hyperthyroidism gives you a revved-up patient. Weight loss, heat intolerance, tremor, fast heart rate. Hypothyroidism gives you a slowed-down patient. Weight gain, cold intolerance, fatigue, constipation. Second, is this acute or chronic? The acute presentations, Thyroid Storm and Myxedema Coma, are emergencies you must recognize instantly. If you see altered mental status with thyroid dysfunction, think emergency. Let me give you the buzzword combinations that scream specific diagnoses. When you see a young woman with a diffuse goiter, bulging eyes, and pretibial myxedema, that is Graves' disease until proven otherwise. A middle-aged woman with a painless goiter, fatigue, and positive thyroid peroxidase antibodies points to Hashimoto thyroiditis, a painful tender thyroid after a recent viral infection with elevated inflammatory markers screams subacute thyroiditis. These patterns are gold on test day. Here is our first case. Read through this vignette. A 32-year-old woman with 6 months of fatigue, weight gain, constipation, cold intolerance. Classic hypothyroid symptoms. Her exam shows bradycardia, dry skin, periorbital puffiness, and delayed reflexes, all pointing to hypothyroidism. Labs confirm it. Elevated thyroid stimulating hormone, low free T4. Before I reveal the answer, think about what the question is really asking. They have already given you the diagnosis. What do they want you to do next? Let us walk through this. The clues are unmistakable for hypothyroidism, and the labs confirm primary hypothyroidism with high thyroid stimulating hormone and low T4. Here is the test-taking strategy. When the diagnosis is already clear, boards want you to treat, not order more tests. Option D, measuring antibodies, would tell you the cause is likely Hashimoto, but it does not change what you do next. You still start levothyroxine. The correct answer is C. This is a common board pattern. Do not overthink it. When the diagnosis is made, treat. Case 2. A young woman with classic hyperthyroid symptoms, weight loss, tremor, palpitations, heat intolerance. But here is the key finding that narrows your differential immediately. Prominent eyes, bilateral proptosis, combined with a diffuse goiter. What diagnosis has proptosis as a specific finding? Think about that before we continue. The proptosis is the key. Among all causes of hyperthyroidism, only Graves' disease causes eye findings. This is because Graves is an autoimmune disease where antibodies attack both the thyroid and the orbital tissues. Let me show you how to eliminate the other answers. Toxic multinodular goiter causes hyperthyroidism, but does not affect the eyes. Subacute thyroiditis would have a painful, tender thyroid, not what we see here. A pituitary adenoma secreting thyroid-stimulating hormone would show elevated, not suppressed, thyroid-stimulating hormone. And factitious hyperthyroidism from taking thyroid hormone would not cause a goiter. Answer B, Graves' disease, is correct. Proptosis equals Graves. Period. Here are the management pearls boards love to test. For symptomatic control, beta blockers come first. They rapidly control the tachycardia, tremor, and anxiety. Propranolol is often preferred because it also blocks the conversion of T4 to the more active T3 in peripheral tissues. For definitive treatment, you have 3 options: antithyroid drugs, radioactive iodine, or surgery. The high yield point for boards, Propylthiouracil is preferred in the first trimester of pregnancy because methimazole has teratogenic effects. After the first trimester, switch to methimazole because of propylthiouracil liver toxicity risk. Case 3. This is a bread-and-butter board question about thyroid nodule workup. A 45-year-old woman with an incidentally discovered 2-centimeter nodule. She is asymptomatic with normal thyroid function. No red flag history. What is your next step? This tests whether you know the standard algorithm for Thyroid Nodule Evaluation. This question tests the thyroid nodule algorithm. Step 1 is always check thyroid-stimulating hormone, which was already done and is normal. With a normal thyroid-stimulating hormone, the next step is thyroid ultrasound. Why not jump straight to biopsy? Because ultrasound tells you which nodules need biopsy based on their characteristics. A simple cyst might not need biopsy at all. A nodule with calcifications, irregular margins, or concerning vascularity would definitely need fine needle aspiration. The answer is B, thyroid ultrasound. Remember, thyroid-stimulating hormone first, then ultrasound, then potentially fine needle aspiration based on ultrasound findings. Case 4. A patient with known Graves' disease who stopped her medication now has fever, altered mental status, and extreme tachycardia. This is a medical emergency. Before I give you the answer, recognize what this is and understand why the treatment is what it is. This is not a subtle case. This is Thyroid Storm, the triad of fever, altered mental status, and cardiovascular compromise in a hyperthyroid patient is pathognomonic. Treatment requires multiple drugs because you need to block every step. Beta blocker controls the cardiac symptoms immediately. Propylthiouracil blocks new hormone synthesis. Iodine blocks hormone release, but you must give it after the antithyroid drug. Otherwise, the iodine provides substrate for making more hormone. Steroids block peripheral T4 to T3 conversion and treat the adrenal insufficiency that often accompanies thyroid storm. The answer is B. Remember, you cannot give iodine without giving an antithyroid drug first. Boards love testing this sequence. Case 5. An elderly woman found unresponsive in winter with hypothermia, bradycardia, hypertension, hypoventilation, and profoundly elevated thyroid-stimulating hormone. The physical exam shows classic myxedema findings. This is the hypothyroid emergency, the counterpart to thyroid storm. What is the most critical intervention? This is Myxedema Coma. Think of it as the opposite of thyroid storm. Instead of a revved-up patient, you have a completely shut-down patient, cold, slow, unconscious. The key treatment points. You must use intravenous thyroid hormone because the gut is not working properly. You must give steroids because many of these patients have coexisting adrenal insufficiency, and giving thyroid hormone without steroids can precipitate an adrenal crisis. The answer is B. Warming blankets alone are insufficient. Oral medications will not be absorbed. Testing delays treatment in an emergency. This is a situation where you treat first, confirm later. Case 6. A young woman with confirmed papillary thyroid carcinoma on biopsy. This question is testing whether you know the histologic and clinical features that distinguish papillary from other thyroid cancers. This is pure pattern recognition that boards love to test. Let us break down thyroid cancer types. Papillary is the most common and has the best prognosis. Its buzzword is psammoma bodies, those concentric calcifications on histology. It also shows orphan Annie I nuclei. It spreads through lymphatics to cervical lymph nodes. Follicular cancer spreads through bloodstream to bone and lungs. Medullary cancer comes from the C cells that make calcitonin, and it is associated with multiple endocrine neoplasia type 2. Anaplastic cancer occurs in elderly patients and has the worst prognosis. The answer is C. When you see psammoma bodies and thyroid in the same question, the answer is papillary carcinoma. Let us wrap up with your key takeaways. For hypo versus hyperthyroidism, memorize the buzzword clusters. For thyroid nodules, remember the algorithm flows from thyroid-stimulating hormone to ultrasound to biopsy when needed. For thyroid storm, know the multi-drug regimen and that iodine must follow the antithyroid drug. For myxedema coma, treatment is intravenous thyroid hormone with steroids. For thyroid cancers, remember papillary has psammoma bodies and the best prognosis, while medullary comes from C cells and associates with multiple endocrine neoplasia type 2. For the complete review of these concepts, check your first aid and UWorld. If you found this helpful, please like and subscribe. And remember, for personalized tutoring and residency advising, visit us at roadmaptoresidency.com. Good luck on your boards.